So good evening, everyone. I am Dr. Devashish Palkar. I am the Faculty of Psychiatry for Nextillo. And before starting my presentation, I would like to express gratitude to Dr. Sunil Sharma sir and the entire team of Nextillo for organizing this wonderful session wherein we are discussing live about mental status examination in psychiatry. I'll just wait for a couple of minutes for the participants to join in, and then we'll start. So good evening, everyone. I am Dr. Devashish Palkar. All right. So now that most of you have joined in, I would just like to start off with the mental status examination. So why mental status examination is important and what is mental status examination? We will first understand that. So when I say mental status examination, I mean to say that we want to understand what is exactly going on in the mind of the patient at that particular point of time. And mental status examination is an important part of the clinical assessment process in neurological and psychiatric practice, without which the history taking part is not complete. So it is a structured way of observing and describing a patient's psychological functioning at a given point in time under the domains of appearance, attitude, behavior, mood and affect, speech, thought process, thought content, perception, cognition, insight, and judgment. We'll look at each of the following domains in the subsequent slides. So why mental status examination is needed is that the purpose of MSc is to obtain a comprehensive cross-sectional description of the patient's mental, which, when combined with the biographical and historical information of the psychiatric history, allows the clinician to make an accurate diagnosis and formulation. So basically, if we talk about the history taking part in psychiatry, then we take the history from both the patient as well as the relatives, the informants who have arrived with the patient. Along with that, then we start having the process of conversation with the patient, wherein we ask specific questions to elicit how the person is feeling, what the person is thinking. We observe what the person is doing while we are taking the interview. All this basically comprises the mental status examination. And when we do the mental status examination, we are able to arrive at a proper diagnosis, and then based on the history, we formulate the treatment that is necessary with that particular case. Now we generally start mental status examination with the general appearance. So general appearance comprises of what we observe when the patient walks into our OPD. So we make assumptions about what must be his apparent age, what must be his height, weight, how is he groomed, is the dress that he's wearing. Based on the physical features, we can even identify something such as that features of alcoholism. For example, the person who has having malnutrition or nicotine stains or dental erosion or a rash around the mouth or from inhalant abuse or needle track marks from intravenous drug abuse, all these things can be understood based on the appearance. Observations can also include any order which might suggest poor personal hygiene. For example, the person has been consuming alcohol for a long period of time. Then I'll just check with the slides once. Okay. So as we were discussing, why mental status examination is important is because once you have talked with the patient and once you have interacted with the patient and taken the history of the patient, then the final target of a history taking is to arrive at a particular diagnosis, which is why it is important to conduct MSc in detail, right? So we'll go further and see what we actually do in mental status examination. So in mental status examination, as we discussed, we generally start with the appearance of the person. So when a person walks into our OPD, we try to estimate what must be the person's apparent age, height, weight, and how the person has dressed himself, how the person has groomed himself. After that, we look for any physical features. Say, for example, if the person is a disorder, then there will be signs and symptoms suggestive of malnutrition, or there will be nicotine stains, or there will be dental erosions, or if the person is consuming inhalants, then there will be rash around the mouth, or if the person is an intravenous drug user, then there will be needle stick marks which might be visible on his forearms. Also, while we are observing the person, it is important to keep all our senses open. So if a person comes to us and he has bad odor emanating from him, that indicates that the person has a poor sense of personal hygiene, which means that he has extremely neglected himself, and the person either is consuming alcohol, then we can have a smell of alcohol as well, or the person, if he has a significant weight loss, then the person could be suffering from any other physical illness or depressive disorder, anorexia nervosa, or chronic anxiety. So this is why physical appearance becomes an important topic. Now, for example, a person walks into our OPD, and this is what we see when the person walks into our OPD. The person is wearing bright clothes. The person is put on multiple bizarre clothing. At a particular point of time, it is important to understand that this could be the presentation in case of a mania, where the person has extreme sense of well-grooming, the person has exaggerated mannerisms in which the person walks. He considers himself to be extra special. At that point of time, he might be wearing clothing which is very bizarre. So this might suggest mania. While the person who is very unkempt, who has worn dirty clothes, might suggest that a person is suffering from a long-standing disorder like schizophrenia or depression. Another important thing to understand is attitude. Now, when I talk about attitude, it means how we are able to develop a rapport with the patient. Is the patient cooperative for the interview? It refers to patient's approach to the interview process and the quality of information that we obtain during the assessment. For example, if we have to mention about MSc, then rapport could be established with ease. It could be very easily established or over familiar. For example, a person of bipolar mania, now he is very over talkative with the doctors. He will come and talk as if he is a long lost friend of the doctor. So in that case, the attitude would be, which rapport would be very easily established, or the person will be over familiar. Also, in case of persons who are paranoid, that is, who have delusion of persecution or who are very suspicious, they might not establish the rapport as easily. And in that case, we say that the rapport is difficult to establish or the person is guarded. So this is something that we need to keep in mind. Then we look for the behavior. So in behavior, we look for any observed repetitive movements. For example, repetitive tics or mannerisms or any stereotypies or gait disturbances. So generally, tics are involuntary muscle movements of specific group of muscles. Mannerisms and stereotypies are generally voluntary. What is the difference between mannerism and stereotypy is that mannerisms are exaggerations of the normal goal-directed movement. So for example, a person who wears spectacles. So generally, those people have this kind of a habit that they constantly keep on adjusting their spectacles. Or people might just keep adjusting their hair. So this is a kind of mannerism if it goes on repeatedly and it goes on continuously. Whereas stereotypy is a movement which is not at all goal directed. So for example, a person does something like this. So it is not goal directed, but it is continuously happening. So that is a stereotypy. And person might have any gait disturbance when he walks into our OPD, right? Also important to understand is eye-to-eye contact. Now, generally, when we are talking or conversing with any person, the person tries to maintain an eye-to-eye contact when he is communicating. But a person who is depressed, has downcast eyes, so he will not try and look in the eyes of the examiner. Or the person who has schizophrenia, he'll be very suspicious, he'll be very paranoid. He might not establish eye contact with the examiner. So that is why it is important to understand this. Then comes the psychomotor activity. Now, when I say psychomotor, it refers to how the brain's mental processes affect our physical movement. So, for example, psychomotor activity can be increased wherein we say that the person has psychomotor activity, or psychomotor activity may be reduced, which is we say psychomotor retardation. So in case of mania, the person might make on exaggerated movements. He might just keep walking around in the OPD, might not sit at one place, very distractible. In that way, we say that the person has increased psychomotor activity. Whereas in case of depression, the person sits at one place, does not move his body, has a downcast eyes. In that case, we can say that the person has psychomotor retardation. Another important disturbance of psychomotor activity specifically is called as catatonia. Now, it is important to understand catatonia because there might be certain MCQs that get asked on catatonia. So, which is why we need to understand the signs and symptoms of catatonia in detail. Now, catatonia, as I said, is a psychomotor disturbance. In case of catatonia, generally there are constellation of certain signs and symptoms which are either observed or elicited by the examiner. Now, catatonia is said when 3 out of the following 12 symptoms are present in the patient. Which are these? So we'll start off with one by one and I'll discuss everything in detail. So first is stupor. Now, stupor means that the person does not have any psychomotor activity and he is not actively relating to the environment. So even if you call the person or even if you make a noise, the person does not respond. That is, the person is in a state of stupor. Then comes two important terminologies that we need to understand is posturing and catalepsy. Now, in case of posturing, the person spontaneously and actively maintains a posture against gravity. For example, if you can see in this diagram, the person has spontaneously maintained posture against gravity. He has kept his hand like this even before the examiner has asked him to do. And he maintains this kind of a posture for a long enough time, which is why we call it posturing. In case of catalepsy, what happens is that the movement against gravity, the posture against gravity is induced by the examiner. So for example, if I am the examiner and I put the hand of the patient in this manner, and even without giving any instruction to him, the patient just keeps on maintaining hand like this, then that is called as catalepsy. Another important terminology in case of catatonia is waxy flexibility. Now, waxy means it can be molded like a wax. Wax यानी कि मोम. So मोमबत्ती का जो wax होता है उसकी तरह. So flexibility means the person can be flexed. His body can be bent just like you are molding a wax. So if you just give slight pressure, the person keeps his hands, it moves, it is as flexible as a wax. So there is just slight even resistance to any positioning by the examiner. That is called as waxy flexibility. Then comes mutism. So the person might not have any verbal output or might speak just a few words which are inaudible. That is called as mutism. Then there is something called as negativism. In negativism, the person either does not respond to any instruction. For example, if I ask him to shake hands with me and I put my hand forward, he does not respond in the same manner. Either he keeps his hand with him or he even withdraws it further, which is called as negativism. Then there is something called as mannerism, which I already described. So mannerism is basically odd circumstantial caricature of normal actions. So normal actions, if they keep on repeating beyond the point of relevance, then it is called as mannerism. If these are repetitive, abnormal, frequent, non-goal-directed movements, then it is called as stereotypy. Then there is something called as grimacing. Grimacing means the person moves his face, keeps making some facial movements. Like for example, he might just keep smiling or he might just keep on making faces, which is called as grimacing. And the person might become agitated all of a sudden without any external stimuli. This is called as agitation. Also, two another important signs that can be seen in catatonia is echolalia and echopraxia. So in case of echolalia, the person mimics the speech of that of the examiner. So if I ask him, what is your name? He might just say, what is your name? Rather than giving the answer. Or the person might have mimicked the movements of the examiner. If I put my hand forward, he might also do the same thing. This is called as echopraxia. If I rub my hand over my head, also start doing the same thing. So that is called as echopraxia. Right? So if 3 out of the following 12 symptoms are present, then generally we say that the person is in a state of catatonia. It's important to remember each of the terminologies and what they mean. Once you understand that, you can easily crack any MCQs, right? So next thing that we look for in case of mental status examination is speech. Speech यानी कि person किस तरह से बोल रहा है. So there are certain components that we look for in speech. One is tone, which means how loudly the person is speaking. So for example, a person of mania, he is in a state of grandiosity, बहुत ज्यादा खुश है, तो वो बहुत जोर जोर से चिल्ला चिल्ला के बातें करेगा आपके साथ. ठीक है. Then comes tempo. Tempo means rate or speed of talking. So what is the speed at which he is talking? Whether he is very slow or whether he is talking very fast. That is how we understand what is the tempo. Then comes the volume. Volume means the amount of speech. यानी कि कितना वो बोल रहा है. Then comes something called as prosody. So prosody means, when we talk normally, we emphasize certain words, we add intonations to speech. So when we are talking something, describing some happy event, then we express in that manner, wherein it reflects that we are putting some emotions behind those words. So if that is maintained, then we generally say that the prosody is maintained. But a person who is suffering from depression for a long time, then you might observe that in his speech, the emotional intonations are generally absent or very less. In that case, we say that the prosody is not maintained, right? Then finally, something that is important is reaction time. So what is reaction time is that, suppose I ask the person, what is your name? And he responds immediately, my name is Dr. Devashish. For example, if I tell him, then this is considered a normal reaction time. But if a person takes a pause and responds very late, then we say that the reaction time is increased. So this is how we get an idea from the speech that the person is suffering from any other mood disorder or from any psychotic disorder, etc. Right? Which is why speech is also important. Then we talk about cognition. Now, when I say cognition, so cognition basically means our higher mental functions of the brain. So we start off with something called as consciousness. So there are various levels of consciousness that we need to understand. So first is the alert level, wherein the person is very much normal, awake and responsive. You ask the question, the person responds, is paying attention. That is called an alert state. Then there is something called as lethargic state, wherein the person is drifting off into a stage of sleep, but he needs to make conscious effort to stay awake, or we need to make some extra effort to make him understand the question. This is called as lethargic. Then somnolent means the person is in a stage of sleep. Then comes a stage of obtundation and stupor. Now, obtundation is just before stupor. In case of stupor, what happens is that the person either does not respond, or you need to make very much big effort. For example, we need to give pain sensation to the person to awaken him. And even when the person is awakened, he gives only minor. That is called a stage of stupor, right? So when the person is arousable only with painful stimuli and does not respond to verbal stimuli, that is called a stage of stupor. Whereas in case of coma, the person is not at all arousable. So even if you give pain sensation to the person, he will not be arousable. That is called a stage of coma. After consciousness, we try to assess the orientation of the person. When I say orientation, we try to see whether the person understands what is the time approximately at present without looking at the watch. What is the place the person is at, and who are the persons surrounding him. So for example, the person might say that it is approximately afternoon time, I am in the hospital, which floor of the hospital, and who are the people surrounding me. Now orientation becomes important, because if the person is suffering from a stage of delirium, wherein the person's consciousness is altered, wherein the person's orientation is not intact, the person might not be aware what time it is, what place he is in, and who are the people around him. At that stage of time, we further proceed with the mental status examination, because all other answers the person will give, it will be based on his poor sense of orientation, right? So this is important to understand, that a person who is in delirium, we cannot further go on to describe about MSc findings in detail, right? So moving forward, after consciousness and orientation, we try to check for the patient's attention. Now, what do you mean by attention in terms of psychology is that the person has the ability to attend to a particular stimuli without getting distracted. So there might be instances wherein a patient of, say, bipolar in mania, he might be very easily distracted. He might keep on looking here and there. Or a person who is suffering from paranoid schizophrenia. At that particular point of time, the person is very much hyper vigilant. So he is always suspicious. He keeps on looking here and there. He will not pay attention to your speech, but he will pay attention to the movements that people are making in his vicinity, because he's very suspicious, he's very fearful, right? So this is why attention becomes important. So for the attention, there are certain tests available as well. For example, I can ask you to do 100 minus 7 subtraction up to 5 places. So normally, if you are paying attention to this particular task, you will be able to do this task. So you will say 100 minus 7 is 93, minus 7 more, you will say 86. This way, normally a person can go up to 5 places very easily. If the person has not studied numbers, then we can even say, ask him, for example, ask him to spell the word apple backwards. So instead of A-P-P-L-E-E-L-E, he has to say E-L-P-P-A. Or if the person is illiterate, then we ask him to say the days of the week backwards. So for example, ask him to say from Ravivar se leke Somvar tak दिन की जो हफ्ते के दिन होते हैं उनको उल्टे से बताओ, right? So that is how we can check for the attention. Or we can give him 3 words to register. For example, I can give him 3 words like pen, cap, and sparrow, and ask him to repeat. That will be attention, right? Also, when I ask him to recall what he had registered, then I'm also testing about his immediate memory, right? So memory is also an important part of cognition. So in immediate memory, I'll give him 3 words. The person has to repeat those 3 words. So this is immediate memory. Then there is something called as recent memory. In recent memory, what we do is that ask the person what he generally had for breakfast or what he had for lunch. The person is able to answer it. Then we say that the recent memory is intact. Then comes something called as remote memory, wherein we ask the person events that have happened years back. For example, some childhood memories. We ask him the name of his childhood friends in his school, or we ask him the name of his school. So that way we assess the remote memory. Also, memory can be classified as implicit memory, which is also called as procedural memory, or non-declarative memory. So in implicit or procedural memory, what it contains is that it contains all our skills, all our habits that we have learned with time. So for example, a person who knows how to drive a vehicle, then driving is a part of his implicit memory. He does not need to recall the procedure of driving every time he is driving. So for example, a person who has already learned driving, he does not need to remember that, okay, I need to put my hands on the steering wheel. I need to then put my hand on the clutch. I need to press the gear. He does not have to remember it. It just happens. So this is called as implicit memory, right? But if you know, when we are learning, we need to learn it step by step. But once it is imprinted in our memory, it remains as an implicit memory. This is about skills and habits. There are other types of memories which is called as explicit or declarative memory, where we need to make certain conscious effort to recall that. For example, explicit memory can be divided as either semantic memory or episodic memory. When I say semantic memory means related to language, related to vocabulary, related to grammar. So for example, when I have to write a proper sentence in grammar, I have to remind myself about certain rules. I have to remember about the vocabulary. So this is called as semantic memory. Or the memory could be episodic. Episodic means autobiographic memory happened with the person. So for example, if I ask the person that, what were you doing when India won the 2011 Cricket World Cup? Then the person has to go back in his mind and try to understand what he was doing, try to recall it. So that is episodic memory, and it is declarative. The person has to declare it. It is explicit. The person has to make some conscious effort to recall it. So this is the difference between implicit memory and the explicit memory, right? Moving forward, what we assess in cognition is intelligence. So intelligence means the general fund of knowledge. For example, there are specific tests also available, which is called as the IQ test or the intelligent quotient test. But generally, when we are taking the interview with the patient, we do not generally go for the IQ test to begin with. We ask him general fund of knowledge questions. So for example, if a person is of Indian origin, as is an adult, then we expect that the person should at least know what is the capital of India, who is the Prime Minister of India. So we ask him such basic question based upon his educational level, of course. Or we might give him some simple calculation skills. So for example, we might tell him rupees and you have to buy dairy milk worth 5 rupees. So how many dairy milks will you be able to buy? So this is how we assess for the intelligence. So moving forward, in cognition, we also test for the abstract thinking. Now, this is very important from the point of view of MCQs. So abstraction means the highest level of thinking. It involves ability to form concepts. So for example, to know about the abstract thinking, we give certain tests. So one of the commonly used tests is the proverb test, in which we ask the person a specific proverb, or if the person is from Hindi speaking area, we give him a muhavra. So for example, I can give him a muhavra that हाथों की पांचों उंगलियां एक समान नहीं होती. So इस मुहावरे का मतलब क्या होता है? Now the person has to explain it to me in abstract terminologies. Now you know that it means that जिन जिन लोगों को हम मिलते हैं सब लोग एक समान नहीं होते. So not every people we meet are similar, right? So that is what it abstractly means. But if the person's abstract thinking is impaired, then he might just say, हाँ सर देखो हाथों की पांचों उंगलियां तो एक समान नहीं होती, सही बात है. So in that case, we say that the abstract is concrete or it is impaired. Generally, it is seen in patients of psychosis like schizophrenia. Then another test that we can do to understand abstract thinking of the person is to give him a test of similarities versus differences. For example, if I ask the person to give me similarities and difference between bird and an aeroplane, is he able to think behind it? Is he able to give me some good explanations, some good similarities and differences? Then we decide whether the person's abstraction is intact or it is impaired. Moving forward, we also test for the judgment. So what judgment means is that it is the ability to take decisions according to a specific situation. So for example, there are three aspects of a judgment. One is the test judgment, another is the social judgment, and then is the personal judgment. So in test judgment, we give a situation to a person. For example, if I say that if you are traveling on a road and you see someone on the roadside, so what will you do? So a normal rational explanation behind that could be, you will try to lift the wallet up, you will see if the wallet contains anybody's address or phone number, or you will try to return it to a traffic police or to a police in particular. So this is how a person who has his judgment intact would react. But a person who has his judgment impaired would say that, yeah, I'll take the wallet, I'll throw the money around, I'll distribute it to poor people, or anything, which is something that is beyond accepted rationally. So that is when we say that the test judgment is impaired. Or we ask him, or we see how the person is behaving in a social situation. For example, is the person behaving well with the hospital staff? Is he interacting normally with the doctors? Is he cooperating or not? So that is the social judgment. In that case, if the person is doing it well, then we say that the social judgment is intact. And finally, we also assess for the personal judgment, which means we ask the person, what is his plan going forward? So for example, after coming to hospital, taking treatment, what does he want to do further in his life? What does he want in the future? So by that, his explanations, we get to know about the personal judgment, right? So moving forward, we also assess the person's insight. So when I say insight, I mean to say that we assess about the awareness of his illness. So whether the person is aware about his illness or not. For example, a person who has psychosis, he has delusions, he has hallucinations, he might not have an idea that he is suffering from some illness. So he might just say that, "Mujhe kuch nahi hua sahab." So that is complete denial. I do not suffer from anything. That is complete denial. So that is grade 1 insight. Then there is something called as grade 2 insight, wherein the person has some awareness, but he still denies it at the same time. So person says, हाँ कुछ तो हो रहा है, ये मेरे घर वाले सब बोल रहे हैं, पर पता नहीं सर, ऐसा मुझे तो नहीं लगता कुछ हो रहा है, right? So sometimes he might say he's aware, sometimes he might deny it. So that is grade 2 insight. Grade 3 insight is the person is aware of his being sick, but he attributes it to external or physical factors. For example, the person has delusions, he has hallucinations, he feels that people who are trying to attack him, but he is rather not able to explain that, and he instead says कि हाँ वो पड़ोसी ने मेरे पे ऊपर कुछ काला जादू कर दिया है, इस वजह से मैं बीमार हूँ. So he is attributing it to some external factors or physical factors. That is called as grade 3 insight. Grade 4 is the intellectual insight, wherein the person understands that something abnormal is going on in his own mind. The person says that he is fearful, he is fearing that someone might actually harm him, but he knows that there is nobody around, but he is still fearful. So that is intellectual insight. But in intellectual insight, the person is not making any effort to continue with the treatment. If the person starts making effort to seek treatment, to follow up with the doctor, and to stick to the compliance, then that is called as emotional insight. That is the grade 5, which is the highest level of insight. Now, generally, we see that when we start treatment, the grades of insight, they start to increase. So, for example, when the person was in complete denial, then he starts to accept that he has some illness. And finally, he gains an insight into his own illness, which is the emotional insight, where he takes patients regularly, he follows up with the counselor, he follows up with the social worker. That is what we try to achieve with the help of treatment. So now, I'll just want to remind the viewers here that Nextillo is giving currently an offer wherein you can register for our app for 3 months at just ₹89. So this is a very exciting offer, especially for those FMGE students as well as NEET PG aspirants, wherein financial issues might be there. So please understand that tough times never last, but medicos do, and which is why we are trying to provide you a helping hand. So if you want, you can register for our Nextillo app. We'll move forward after finishing with the cognition. Now we'll move across to thought. Now, thought is something that we assess in mental status examination. So thought means what the person is thinking, how the person is thinking, what is the content of his thoughts. So generally we assess thought on the basis of his speech. क्या बोल रहा है, उसके basis पे से हम इस basis का अनुमान लगाते हैं कि क्या person सोच रहा है, right? Because we cannot direct his thoughts. We look at the speech sample that the person is saying. So now it is said that a normal healthy thinking should actually have constancy, continuity, and organization. So constancy means that the person sticks to the topic of conversation. So for example, if you are talking about cricket, then the person sticks to that topic of cricket. He does not start talking about the Russia-Ukraine war. So that is called as constancy. When I say continuity, the person is able to put on few sentences and make something out of it. So for example, if he says a particular sentence on cricket, then is he able to continue with that or not? That is called as continuity. And finally, organization means if he is able to put all the sentences together and make something meaningful out of it, that is called as organization. So normal thinking has constancy, continuity, and organization, right? There might come an MCQ wherein they give you 4 choices. They might just say normal thinking contains all of the following except, and you need to rule out the wrong choice, right? So moving further, let us understand what is formal thought disorder. So when I say formal thought disorder, basically what formal thought disorder means, we are looking at how the thought is getting formed. So the thought is getting formed in a structured, organized manner, or the thought is not formed in a structured manner. When we say formal thought disorder, we try to mean कि जो thought है वो किस प्रकार से बन रहा है, how the thought is formed. So to assess for it, generally we give a neutral topic to discuss. For example, a person comes to me in the OPD, then I ask him to talk about his village. कि आपके गांव के बारे में बताइए मुझे, आपके फैमिली के बारे में बताइए, अभी जो भारत देश में पॉलिटिक्स के बारे में चल रहा है उसके बारे में बताइए, डिपेंडिंग ऑन ऑब्वियसली द पेशेंट्स social and the intellectual level. And then we try to assess how his thoughts are getting formed. So if the thoughts are not properly organized, if there is no structure behind the thoughts, then there can be certain formal thought disorders, which is what is important to look for. So what is formal thought disorder? Examples could be, so for example, loosening of association could be a formal thought disorder. So in loosening of association, what happens is, here the individual parts of one thought process, they are not connected with each other by meaning. एक thought process है जिसके parts है which are not connected with each other by meaning, that is called as loosening of association. So उन दोनों के बीच में जो association है, that is lost, which is why we call there is loosening of association. So if I give two example, then suppose consider this example that I like to dance, all people have hands. So person who says this kind of a sentence, so if you understand this kind of a sentence, then you will realize that actually this sentence makes no meaning, because there are two parts of this one thought process, and both of these thoughts individually they might mean something, but put together they do not convey any sort of a meaning. I like to dance, all people have hands. So there is loosening of association. And generally loosening of association is seen in patients who are suffering from schizophrenia, form of psychosis. There is something else which is called as derailment. So what happens in case of derailment is there is loosening of association between successive thoughts. So for example, one thought may be normal. For example, a person might say, I am going to Bangalore, and the next thought the person says, Ramesh is very smart. Now, if you try to look at this, then these two thoughts, they have no logical relation between each other, right? So I'm going to Bangalore, Ramesh is very smart. These two thoughts independently might mean something, but put together, they do not mean anything. So this is called as derailment. Then if there is extremely difficult to understand speech, wherein the loss of organization is so severe that you're not able to derive any meaning out of it, then that is what is called as word salad, or we also call this as incoherence or schizophasia, because that is the speech sample that you will find in a patient who has schizophrenia, which is untreated for a long time. So for example, a person might just put together different words like I, Delhi, sing football. Now this means nothing, right? It does not convey any logic, any meaningful situation out of this terminologies that the person is speaking, which is called as incoherence or word salad, right? So moving forward, there can also be something called as circumstantiality. So it is important to understand circumstantiality. Here, the thought progresses with over-inclusion of unnecessary details, but ultimately the goal is reached. For example, if you ask the person, who all stay in your home? And the person starts saying, sir, I was born in 1990. My brother was born in 1992. So then he graduated and shifted to Delhi. And my mother died around 4 years back. And I married around 6 years ago. Now at my home, I live with my wife, my father, and my 4-year-old son. So finally, you get an idea that who all are living at his home. But the patient included so many unnecessary details, starting from his birth to explaining about his marriage, explaining about his brother, which was not needed. So this is called as circumstantiality, wherein the thought progresses with over of unnecessary details, but finally the goal is reached. So this is circumstantiality. Similar to circumstantiality, but slightly different is tangentiality. In tangentiality, what happens is, here the thought is related to the goal in a very tangential manner, or in such a distant manner that the goal is not reached. For example, the person starts talking about something wherein you feel that the person will arrive at a goal, but the person ultimately does not arrive at the goal. So, for example, if you consider a similar question, if I ask a person, who all are staying in your home? And the person says, sir, I was born in 1990 and my brother was born in 1992. Sir, we were born in Lalpura, but then my father took a job and we went to Rampura, where we grew up. Sir, Rampur is named after Lord Ram, who is the protector of universe. Sir, someday you should come and visit the famous Ramji Mandir temple in Rampur. And the thought ends there. Finally, you could not even get who all are staying at his home. He started with something like family, but it proceeded in a very tangential manner and was ultimately not reached, right? So this is tangentiality. Then there is something called as perseveration. Now, perseveration could also be included in stream of thought disorders, but if you look at the textbooks of psychiatry, they have also included perseveration as a formal thought disorder, which is how the structure and the organization of the thought process is, which is why it is called as formal thought disorder. So in perseveration, what happens is that here the person persistently gives same response beyond a point of relevance. यानी कि बार बार एक इंसान similar response दे रहा है even when that is no longer relevant. So first answer जो देगा that might be relevant, but next time onwards the answer loses its relevance. For example, if I ask someone, who is your favorite cricketer? The person says Virat Kohli. Then I ask, what is the name of your father? The person again says Virat Kohli. What is the name of your brother? He again says Virat Kohli. What is the name of your school? He again says Virat Kohli. So he is persistently giving same response beyond a point of relevance. This is perseveration. Important to remember is that first stimuli and the first answer could be very much correct in this case, right? So this is how perseveration is. Then there is something called as neologism. In neologism, a new word is created whose derivation cannot be understood. So for example, a person makes completely new word, which is not even mentioned in the dictionary. It is his own creation and the person gives a meaning to it. You might sometimes understand it, you might not understand it. For example, it is a rare finding, generally highly related to schizophrenia. The person who comes to me in OPD and he says, sir, I came to your hospital riding on my valley whoop. Now, he intended to say that he came on his Activa, a two-wheeler, but he gives it a new terminology and calls it valley whoop. So this is neologism, right? Moving on further, we discuss about the content of thought disorders. So up till now, we were discussing formal thought disorder, which means how the thought is formed, how it is organized, and how it is. Now we move on to content of thought disorder, which means thought किस बारे में है, person क्या सोच रहा है. So क्या सोच रहा है, that is the content of the thought. In content of thought, important to understand is delusion. Now, do not forget that delusion is a content of thought disorder, but when we'll describe later on hallucination, so hallucination is a disorder of perception, right? We'll go on further, but please understand that delusions and hallucination, though they are spoken of together, they are completely different. Delusion is a content of thought disorder, whereas hallucination is a disorder of perception. So what is delusion? अगर हिंदी में ट्रांसलेशन किया जाए तो पर्सन को वहम है. क्या है वहम? So what is delusion? It is a false form, fixed, unshakable belief that is out of keeping with an individual's educational, social, cultural background and which persists despite providing a contradictory evidence. Each and every word here is important. So it is a false belief, यानी कि वो belief false है. It is form. The person is form कि हाँ वो उसके लिए तो सही है. बाकी भले दुनिया के लिए वो गलत हो पर उसके लिए वो सही है. So it is unshakable. You cannot shake it. आप उसको एक कोई contradictory evidence भी दोगे, then also he will not believe. For example, a person coming to my OPD says that उसके neighbors उसे मारना चाहते हैं. His neighbors want to kill him. He is very fearful of that and he is convinced. He is very strong in his belief that they want to kill him. Now, his family members know that it is actually false. They try to tell him कि अरे ऐसा नहीं है यार, वो देख कितने सज्जन लोग हैं, वो ऐसा क्यों करना चाहेंगे? Still the person is not convinced. So this is when we call that a person has a delusion. And in this case, when the person feels that people are out to get him, people are trying to harm him, then that is called as delusion of persecution. Now delusions can be again of two types. One is primary delusion and the other is secondary delusion. So primary delusion is something that is also called as autochthonous, which means कोई existing psychopathology, existing कोई disorder अभी नहीं है, and the delusion comes off as the first sign and symptom of that particular psychopathology. For example, a person of schizophrenia, first sign and symptom that you came across, that was the delusion. So this is called as primary delusion. But delusions can also be secondary to other disorders. For example, secondary to mood disorders like mania. So in case of mania, the person, because he has extreme sense of well-being, he feels that he is very powerful, he might have a sense of grandiosity, which is called as delusion of grandiosity, wherein he might say that मैं तो दुनिया का बड़ा योद्धा हूँ, मैं दुनिया का रखवाला हूँ, and he is firmly believing that. So that is called as delusion of grandiosity. But here, this delusion is secondary to the existing psychopathology, which is mania, which is a mood disorder. So इस mood disorder की वजह से उसे delusion हुआ. That is why it is secondary delusion, right? So this is the difference. So based on the content, we can understand what are the various types of delusion that can be. Type of delusion that is most commonly seen in patients of schizophrenia is delusion of persecution that I just mentioned, wherein the person feels that people are out to either get him, or they are trying to trouble his family members, or they are trying to steal his property. They are trying to persecute him. Then there could be something called as delusion of reference, wherein the person feels that he is the center of all the topics that are being discussed. So for example, if a person goes out on the streets, he sees a few people talking amongst themselves, then he feels that people mere bare mein hi baat kar rahe, people are discussing about me, and he is very strongly believing it, and he runs away from that place. That is called as delusion of reference. He feels that people are talking about him, they are making gestures around him, they are making reference towards him. That is called as delusion of reference. Then in case of mania, we might have a delusion of grandiosity. In grandiosity, the person might believe that he is very superior. He might say, मैं तो भगवान राम का दूसरा अवतार हूँ. He might say that Narendra Modi तो मेरा, but actually it might not be true. So this is called as delusion of grandiosity. Then there is something called as delusion of love, which is also called as erotomania, or it is also called as de-Clermont syndrome. Important to understand and remember these three terminologies because it could be asked in MCQ. So for example, they will say de-Clermont syndrome. What is the delusion? So let us understand with this example. So understand, for example, take this example कि एक काम वाली बाई है जो उसका काम है कि ground की सफाई करना. Now one day she was cleaning the ground, and at that time, for example, a cricketer, well-known cricketer, for example, MS Dhoni was practicing on the same ground. Now, because MS Dhoni is a jovial person, he looked at her as he would look at other people. He smiled and waved a hand at her. अब उसे ये लगने लगा कि because MS Dhoni ने मेरे सामने smile किया, he is in love with me. So generally, delusion of love is seen in case of social structure, wherein a person coming from a lower socio-occupational background believes that from a higher socio-occupational background is in love with him or her. And generally, it is seen more commonly in case of females. So this is called delusion of love or erotomania, also called as de-Clermont syndrome. Another syndrome that could be there is delusion of infidelity, also called as morbid jealousy or Othello syndrome. In this case, the person believes that his spouse is cheating on him or her, and he is firmly convinced about that. कि मेरी wife या मेरा husband मुझ पे cheat कर रहा है, and he is strongly convinced, despite giving all the contradictory evidence, he will not be convinced, right? Then there could be something called as delusion of guilt or delusion of sin, wherein the person believes that सारी दुनिया में बुरी चीजें हो रही है, उसकी फैमिली के साथ जो बुरी चीजें हो रही है, वो उसी की वजह से हो रही है, उसी की गलती की वजह से हो रही है. So he is taking unnecessary guilt on himself, and it is to a level of delusion, which is called as delusion of guilt. या फिर person says that मैंने कुछ बड़ा पाप कर लिया है मेरे जीवन में, where in that case it could be delusion of sin. Also there could be delusion of nihilism or delusion of negation. Now it is seen in severe cases of depression, wherein the person feels that दुनिया सब बर्बाद हो चुकी है, या तो मेरी बॉडी बर्बाद हो चुकी है, मेरे अंदर की मेरी इंटेस्टाइन है वो रॉट हो चुकी है. So this kind of negative statements or negation, wherein the world is coming to an end, my body has stopped functioning totally, मेरी intestines पूरी rotten हो चुकी है. These kind of statements, they are called as delusion of nihilism. It could be a part of delusion of nihilism. Also, delusion of nihilism is very commonly seen in one of the syndromes called as Cotard syndrome. So if they tell you an MCQ that Cotard syndrome, what is the commonest delusion that is seen? Then it is delusion of nihilism or negation. Also, Cotard syndrome is called as walking corpse syndrome, wherein the person believes that walking corpse, यानी कि चलता फिरता वो एक मरा हुआ इंसान है. So you might say that my body parts are dead, I am dead, I do not exist. So these kind of statements which the person gives and firmly believes in it, then it could be Cotard syndrome. Now another different types of delusions. So another way wherein we can have delusions is bizarre delusion. So what is bizarre delusion is that bizarre यानी कि a delusion that is scientifically not possible and it is culturally implausible. यानी कि scientifically you cannot explain कि ऐसा हो सकता है, उस delusion को हम बोलेंगे bizarre delusion. I'll give you a very easy example and you tell me कि whether it is a bizarre delusion or it is a non-bizarre delusion. For example, a person coming to me, a patient of psychosis, he says that his wife is cheating on him. He has delusion of infidelity. And now, could this be true? Could this be scientifically possible that his wife is cheating on him? Could this be culturally plausible? Yes, it might happen that actually the wife is cheating on him. In that case, the delusion is non-bizarre. But what could be a bizarre delusion is, suppose a person comes to me and he says that, sir, मेरे दिमाग के अंदर मार्स से एलियंस ने एक चिप फिट कर दी है और वो लोग मुझे उससे कंट्रोल कर रहे हैं. Put a chip in my head and they are trying to control me through it. Now, is it scientifically demonstrable? Is it scientifically possible? Is it culturally plausible? No, right? So this is called a bizarre delusion. Why we need to understand bizarre delusion is because previously it was believed कि अगर bizarre delusions है, तो most likely it is schizophrenia. But now it is not so because the definition of bizarre delusion can change with changing times, can change with culture as well. For example, this statement, today it might be a bizarre delusion, but who knows? 100 years later, when we actually discover that there are aliens on Mars and they might have this kind of powers, it could be possible as well. But for now, scientifically it is not possible, culturally it is implausible. That is why it is a bizarre delusion, right? Then there can be something called as delusional parasitosis, also called as Ekbom syndrome, wherein the person believes that there are parasites or worms or bugs who have infested his body. यानी कि उसे लगता है कि मेरी शरीर में जंतुओं ने कोई भी हमला कर दिया है और मेरी चमड़ी पे उन्होंने इन्फेस्ट कर लिया. And he is so much convinced that he even has all the kinds of sensation. उसे itching भी हो रही है. He keeps on even scraping the skin and he keeps on showing it to you. कि देखो यहाँ पे सच में देखो यहाँ पे कीड़ा है. But actually you will see that it does not have any germs or any worms, but these are just the scrapings of his own skin. But he is so firm in his mind, he is convinced that yes, these are some bugs. And he even might, pick these bugs up, might bring them to our OPD, which is why it is also called as matchbox sign or Ziploc bag sign. So in olden times, these patients, what they used to do is empty matchbox mein, they would collect the scrapings of their skin and they would bring it to the OPD and they would show it to the doctor because they were so convinced. But the other members were not convinced. So they will show, देखो sir, यहाँ पे सच में तो कीड़े हैं, right? So this is called as matchbox sign, or they might bring a Ziploc bag and they try to show it to you. This is called as matchbox sign, Ziploc bag sign, seen in delusion of parasitosis, a very important syndrome, a very important MCQ, Ekbom syndrome, right? Please remember this. Another type of delusion that we need to know is shared delusional disorder. Now, what do we mean by shared delusional disorder is that there is one primary member in the family who has some psychopathology. For example, a person of head of the family, for example, father है एक family में, उन्हें psychosis हो गया है, and he believes in his delusional world that neighbors want to kill him. Now, because he is so powerful member in the family, he will influence other members in his family, his wife, his children, and ultimately they also start believing कि हाँ सच में वो लोग हम पे मारना चाहते हैं. Actually speaking, they do not have any psychopathology, but because this delusion was primarily present in the father, it got transferred to them by way of either power, by way of repetition, by way of authority. That is called as shared delusional disorder, also folia edux. If you want to understand the example of shared delusional disorder in detail, read about the Burari murder case, right? There is an entire documentary made on Netflix. Read about it. If you want, you can watch it and you'll understand in exact details what I mean by shared delusional disorder and how it could be very dangerous, right? Another important thing to look for is delusion of misidentification, wherein the person wrongly identifies someone as someone else, but it is on a delusional level. So there are two important syndromes that we need to understand. One is the Capgras syndrome and the other is the Fregoli syndrome. Now, Capgras syndrome में basically क्या होता है? Here the person believes that family member has been replaced by a stranger who looks, talks, feels like the family member. यानी कि अगर एक patient है schizophrenia का, psychosis का, he goes to his home, he sees his father, but he says ये मेरे पापा नहीं है, ये कोई stranger है जिन्होंने मेरे पापा का रूप धारण कर लिया है और करना चाहते हैं. So this is Capgras syndrome. Important and easy way to understand this: here the person has delusion towards someone else. He does not have suspicion towards his family members. He does not feel कि उसके पापा उसे मारना चाहते हैं. Here it is that some stranger wants to harm him and he has adopted the role of his father. He is a look-alike of his father. He is an imposter of his father, which is why it is called as imposter syndrome. Also, it is called as delusion of doubles, right? Remember it with an example, you will never forget. Another similar is Fregoli syndrome. Now, people mistake between these two of types of delusions. So I'd just like to clear it with an example. Consider a patient hai. Here the person believes that his known or familiar person has disguised himself as a stranger who wants to kill him. Now, Fregoli syndrome में basically होता क्या है कि the person has a delusion towards his own family members. I'll give you an example from my ward. So I had this patient in my ward, psychiatry ward. वो बंदा था, उसे लगता था कि वो उसे मारना चाहते हैं. Now he had this so strong delusion that हमारे ward boy जो थे वो उन्हें एक बार इंजेक्शन लगाने गए and he got very frightened, very aggressive and he said कि ये ward boy नहीं है, ये एक्चुअल में मेरे फादर है. मेरे फादर ने ये ward boy का रूप धारण कर लिया है और मुझे वो मारना चाहते हैं, ऐसा इंजेक्शन देना चाहते हैं जिससे मैं मर जाऊं. So this is generally what is called as Fregoli syndrome. So this is also called as delusion of intermetamorphosis, right? Here the patient has delusion against his own family members and he feels that a family member can take the role of a stranger, right? Here the person believes that his known or familiar person has disguised himself as a stranger who wants to kill him. This is called as Fregoli syndrome. You can even remember it as family member ही मुझे गोली मारना चाहता है, something like that. So that is Fregoli or Fregoli, right? Just try to remember both these syndromes. Don't confuse, right? If the MCQ comes, it's very easy to understand. Now we'll move further. What we need to understand along with formal thought disorders is that content of thought disorders is that along with delusion, there can be other contents in the content of thought disorders. So what can be there apart from delusion? There could be something called as overvalued idea. So overvalued idea is basically a belief which, because of the excessive emotional tone invested in it, comes to dominate the thinking to an abnormal degree. यानी कि एक ऐसा belief है जिसमें a person has emotionally invested himself very much and now it is in the foreground of his thinking. So he's constantly thinking about that only. So for example, a patient of anorexia nervosa believes that he or she is fat. Actually वो fat नहीं है, but this thought constantly keeps on occurring in the mind of that person. Of course, it is not at a delusional level. Here, if you give the logical explanation, the patient might even understand, which is why it is an overvalued idea and not a delusion. Another thing that we need to understand in the content of thought is obsession. Now, there are two textbooks of psychiatry, which is for psychopathology. Now, it has classified obsession in the disorder of perception. But our comprehensive textbook of psychiatry, which is like the Bible that we use, it has said that obsession is in the content of thought disorder. So don't get confused. Don't keep scratching your head about it. Obsession can be included both in disorder of perception or it could be content of thought disorder as well, right? So, sorry, not a disorder of perception, but disorder wherein the person feels that it is not in control of the person, right? Sorry for that. So, generally, for the time being, just try to understand that obsession is a content of thought disorder. So in content of thought disorder, what I mean by obsession is that obsession is any thought, any image, or any urge that the person keeps on having repeatedly. And these are distressing, these are own thoughts, these are recurrent in nature, these are intrusive, and these are ego dystonic. This with the mnemonic DORID. A thought which is distressing. For example, a person constantly keeps thinking कि मेरे हाथ गंदे हैं, मेरे हाथों में कीटाणु है, and he keeps on washing the hands. This is generally what we see in a patient of OCD. Now OCD में क्या होगा? और ये obsession जो है, it is very distressing. This thought is very distressing to the person. It is intrusive. यानी कि वो बार-बार वो thought आता ही रहता है दिमाग में. It is recurrent, keeps on occurring again and again, and it is ego dystonic. यानी उस person को खुद को वो thought पसंद नहीं है, right? So these are the characteristics of obsession. For the purpose of MCQs, for the time being, just remember that comprehensive textbook of psychiatry has said, and the latest editions have confirmed that this is a content of thought disorder, right? So don't get confused with this. Then we can have something called as ruminations. So in rumination, what happens is there is prolonged, inconclusive chain of thoughts. यानी कि हम अगर कोई बारे में चिंता कर रहे हैं कि मेरी एग्जाम किस तरह से जाएगी, एग्जाम में ये सवाल पूछा जाएगा, ये नहीं आएगा. If we keep on having this kind of thoughts constantly, this is called as ruminations. Also, in content of thought, it is very important to elicit if the person has any thoughts to harm himself, which is what we call as suicidal ideation. In psychiatry, it is very important to go on and ask for it actively. कि क्या person को लगता है कि उसे ऐसे thoughts आ रहे हैं जिससे वो खुद को harm करे. So this is suicidal ideas, right? Clearly demonstrated, clearly elicited. Okay. So moving forward, we have covered about the content of thought. We now cover the possession of thought disorder. So possession of thought का मतलब ये होता है कि normally कैसा है कि I know that my thoughts are my own thoughts. These are not anybody else's thoughts, right? But a person who might think that his thoughts are being controlled by some external agency, then the person might feel that his thoughts are not in his own possession. There in times we say that the person is suffering from disorder of possession of thought, which is also called as alienation phenomena. So there are three types of thought alienation phenomena: thought insertion, thought withdrawal, and thought broadcast. In thought insertion, the person says that कोई external agency है जो मेरे दिमाग में उसके ख्यालात डाल रही है. For example, there are aliens who are putting thoughts in me. This is thought insertion. Thought withdrawal यानी कि कोई external agency है, external person है who is removing the thoughts from his mind. So person says कि मेरे दिमाग में से कोई विचार निकाल ले रहा है. That is thought withdrawal. And thought broadcast is when the person says कि दिमाग में से thoughts निकाल रहा है और वो broadcast भी हो रहे हैं. रेडियो पे से, टीवी पे से, टेलीफोन पे से, मैसेज पे से, सबको मेरे विचार पता भी चल रहे हैं. So this is called as thought broadcast. So these are three important terminologies that you need to remember: thought insertion, thought withdrawal, and thought broadcast. Moving forward, we also have something called as stream of thought disorders. Stream का मतलब कैसा है कि एक जो thought होता है वो किस तरह से बहता है, the flow of thought, how it is flowing. So normally thought होता है, उसकी एक speed होती है and उसकी एक continuity होती है. अगर दोनों में कोई problem हो, गड़बड़ी हो, तो it is what we call as disorder of stream of thought. So what could be there? It could be disorder of thought tempo or thought speed, wherein the thought could be very slow, which we call as retardation or inhibition, or also called as slowing of thinking, or the thought might come one after the other at a very rapid pace, and along with that, the person has a pressured speech. Then in that case, we call that it is a flight of ideas, right? Flight of ideas, very commonly seen in case of mania. एक बार बार thought repeatedly आ रहे हैं, तरह तरह के thoughts आ रहे हैं, and they're coming at such a rapid pace that the person is also speaking very fast, right? So for example, when I ask a person what is his name, the person says मेरा नाम है रमेश, मैं करता हूँ दुनिया को माफ, दुनिया में सब नहीं होते हैं साफ, भगवान ने मुझे बनाया है करने को इंसाफ. So he keeps on having such repetitive thoughts connected with each other, but they might be just connected with one word, or they might be rhyming words, they might be punning words, they might be connected with each other by clangs, यानी कि rhyming है, साफ, माफ, इंसाफ, इस तरह के वो speech दे जा रहा है. या फिर repeatedly तरह तरह के thoughts आ रहे हैं which are coming one after the other at a rapid pace. This is called as flight of ideas. और अगर flight of ideas थोड़े lower level में है, wherein there is not much pressure of speech, यानी कि बहुत ज्यादा वो fast नहीं बोल रहा, but एक ही thought को वो बहुत ज्यादा बढ़ा चढ़ा के बोल रहा है, then that is generally called as prolixity, which is seen in hypomania. For the purpose of MCQs, remember, prolixity is seen in hypomania, flight of ideas seen in patient of mania. Then there could be disorder of thought continuity, which is called as, which are two, thought block, or it could be perseveration. Now perseveration could be included in both stream of thought disorder as well as it could be included in the formal thought disorder as well. So thought block में क्या होता है कि person starts to speak something and then he stops. That's thought block. He stops midway between his thought process. Or perseveration is repeating something beyond the point of relevance, which we already saw previously. Not to confuse perseveration with something called as verbigeration. Now in verbigeration, what happens is the patient keeps on repeating some random words without context, without any stimuli. अगर आप remember करेंगे the example of perseveration that I gave you, here the examiner asked him the question कि who is your favorite cricketer? The person said Virat Kohli, and then he kept on repeating Virat Kohli for all other questions. So एक stimuli present था and the person repeated it, so that is perseveration. In case of verbigeration, there will not be any stimuli. He'll just keep on saying some random words without any stimuli. That is verbigeration. Also, similar terminology like perseveration is called as paralogia, which is seen in Ganser syndrome. अब पैरालोजिया में बेसिकली होता क्या है, द पर्सन गिव्स अप्रोक्सीमेट आंसर्स, यानी कि सही जवाब नहीं दे रहा, वो अप्रोक्सीमेट आंसर्स दे रहा है, और अगर ये तो वो जनरली गैंसर सिंड्रोम बोलते हैं उसे. अब क्या होता है कि फॉर एग्जांपल इफ आई आस्क समवन कि व्हाट इज द कलर ऑफ ग्रास, द पर्सन सेज ब्लू. नाउ ही हैज एक्चुअली सेड अ कलर, but he has not given me the correct answer. The correct answer should have been green, but he instead said blue. So this is called as approximate answer, also called as paralogia, seen in Ganser syndrome. और अगर Ganser syndrome commonly किन लोगों में देखा जाता है, तो it is seen commonly in case of prisoners or jail population, right? So remember this Ganser syndrome, prisoners, paralogia, giving approximate answers. Now we'll come to mood and affect. So what is mood and what is affect? Mood यानी कि what the person is feeling internally. So the long-term feeling state through which all our experiences are filtered, that is generally called as mood. So mood is generally very subjective. It is internal, what the person is feeling, and it is generally longitudinal. तो हम पूछेंगे सवाल, पिछले 1-2 हफ्ते से आपका मन कैसा रह रहा है? पर्सन बहुत उदास रह रहा है. So this is his internal reflection of his emotional state, which is called as mood. Right? So mood is generally a symptom, right? Whereas affect is generally a sign which we observe based on the person's facial expression, based on the person's body language. And affect is generally cross-sectional. So this is something visible, or we might understand it based on the way the person is speaking. So affect is very cross-sectional. यानी कि मैं अभी smile दे सकता हूँ, but internally I might be very depressed, right? So my mood may be depressed, my affect may not be, right? So we need to know whether the mood and affect, are they congruent with each other or not. To give you another example, mood is like a weather, or mood might is like rather we'll say that कि suppose अभी गर्मी का season चल रहा है. So this is mood. Season कौन सी है? This is mood. But if I say the affect, then affect is आज अभी कैसा महसूस हो रहा है. So for example अभी evening का समय तो cool महसूस हो सकता है, right? So that is affect. But overall अगर देखा जाए तो गर्मी का सीजन है, so that is the what is longitudinally happening. So that is mood and this is affect, right? Important to understand this. Do not get confused, right? So how to describe mood and affect? Generally, there are various terminologies that we use. Let us look at it. First is quality. So quality यानी कि how the person is feeling. Whether the person is feeling sad, whether the person is angry, irritable, depressed, or if the person is in a state of mania, then he might even say that I'm feeling very happy. Now we also grade, or we also try to stage of the mood where the person is. Generally, mania mein very important hai. So for example, the person has an elevated mood wherein the person says he's very happy. So he might be in a stage of euphoria wherein the person has increased sense of psychological well-being and happiness, which is generally not in keeping with the ongoing events. यानी कि ongoing events में ऐसा कुछ चल नहीं रहा, फिर भी the person is very happy. So this is euphoria. अब euphoria के साथ person also has an increased psychomotor activity, यानी वो यहाँ वहाँ घूम रहा है, थोड़ा तेज चल रहा है, तो that is called as elation, wherein a person has euphoria along with psychomotor, increased psychomotor activity. Now along with psychomotor activity, अगर साथ साथ the person has delusion of grandiosity, यानी he believes that he is something special, he is a superior person, then the person is in a stage of exaltation. And finally, if the person has extreme sense of rapture, यानी कि इतनी खुशी की ये दुनिया से बाहर है, दुनिया में समा ही नहीं पा रहा, extreme sense of rapture, blissfulness, then that is also called as ecstasy. So these are various stages. We need to understand which stage the person is in if he is in a stage of mania, whether he is euphoric यानी कि खुश है without any reason, elation यानी कि खुश भी है और उसके demonstrable behavior में भी पता चल रहा है, डांस कर रहा है, इधर उधर घूम रहा है, that is elation. Exaltation, wherein the person also has a delusion of grandiosity, and ecstasy, wherein the person is out of the world feeling. So moving further, what else we need to look for? So we need to look for reactivity. So there is something called as range as well and reactivity. These two terms are important when you describe mood and affect. So in case of range यानी कि whenever we talk or have a conversation with anybody, so generally we say some things where we express some sadness also, we say some things where we express some happiness as well, depending on what we are speaking. But if you are talking about things, or if you are expressing only one particular emotion, then we say that the affect is restricted. If the affect is about sadness and it is restricted, then we say that it is restricted to sadness. Or if a person हमेशा खुशी ही है, सिर्फ खुशी के बारे में बात कर रहा है, कोई भी चीज हो वो खुश ही बता रहा है अपने आप को, then it is said that the person is restricted to happiness, right? Or there could be a situation wherein the person keeps on fluctuating between both the extremes, कि एक मोमेंट पे पर्सन अचानक से रोने लग रहा है, अचानक लग रहा है, so that is called as lability. So lability is an unstable affect which fluctuates between the two extremes. It is generally seen in patients of bipolar disorder. Also, it could be seen in organic mental disorders as well. Moving further, what is reactivity? So reactivity यानी कि अगर मैं आपको कोई सिचुएशन दूं, कोई आपको एक कहानी बताऊं जिसमें कोई इमोशंस इन्वॉल्व है, so you will try to react in the same manner. Suppose I tell a sad story, then you will feel or express sadness. If I tell a joke, then you will laugh. So your mood and affect is reactive. But if the person is not reacting to any point of conversation, to any change of topic, then we say that the affect is blunted. Generally, it can be seen in patients of severe depression, also in case of patients of schizophrenia, where the affect is not reactive, it is flattened, or it is also called as blunted. Then there is something called as congruence. अब congruence का मतलब ये है कि मूड जो है पेशेंट ने रिपोर्ट किया और अफेक्ट जो एग्जामिनर ने ऑब्जर्व किया, आर दे सेम? सो फॉर एग्जांपल, इफ अ पर्सन सेज दैट आई एम डिप्रेस्ड, the person's affect also shows कि he has downcast eyes, he is very sad, he has frowning, downcast eyes, then we say that the mood and affect are congruent to each other. But if the person says कि मैं बहुत दुखी हूं and he is smiling, laughing, then we say that the mood and affect are not congruent with each other, right? Then there is something also called as appropriateness, यानी कि क्या उसका जो मूड स्टेट है, क्या उसका जो अफेक्ट है, is it appropriate to the situation? For example, किसी के फ्यूनरल सेरेमनी में गया है एक बंदा, and there he is joking around, he is laughing around, then at that point of time we say that it is inappropriate to the social setting, right? So these are the headings under which we describe mood and affect. Finally, coming to disorders of perception. Now what is perception is that perception एक होता है sensation, यानी कि whatever we see, whatever we feel based on our sense organs, right? So all the sense organs, messages that they receive, that is sensation, and the way in which that message is understood by us, interpreted as perception. So perception can be defined as our recognition and interpretation of any sensory information. So what are the disorders of perception? One can be sensory distortion. So what happens in sensory distortion is that a real object or a stimulus is present, but it is seen in a distorted way. For example, I am able to see this pen, but if I see this pen to be very long, or instead of this pen being cylindrical, I see that this pen has become suddenly circular, then this is called as distortion, sensory distortion. So there is change in intensity or the quality of stimulus or the spatial form of the perception, right? This is called as sensory distortion. For example, अगर हमारे emotions बहुत disturbed है, then we might have different sensitivity to pain, then different sensitivity to touch, wherein we may have hypoesthesia or hyperesthesia due to our intense emotion. Also in case of delirium, यानी कि अगर patient एक delirium, तो उस समय उसका hypoacusis हो सकता है, यानी कि he might not be able to hear voices properly. जो level threshold होता है, that is generally it has become higher. So उसे तुमको loudly बात करना पड़ेगा, clearly बात करना पड़ेगा, तभी वो बंदा आपको समझ पाएगा. Also in case of migraine, opposite might happen. A small stimulus, it might be perceived very loudly. For example, थोड़ा सा voice हो रहा है, but the person might perceive it to be a noise and it might become very distracting to him. So that is called as hyperacusis, which might be seen in migraine. So these are examples of sensory distortion. Moving forward, there can be something called as sensory deception. अब sensory deception में क्या हो रहा है कि there is a new perception that you are getting that may occur or may not be in response to an external stimuli. Now, एक external stimuli, either it can be present or it can be absent, but the perception that you are getting is totally new. Understand that sensory distortion mein I was able to identify that this was pen, but this pen was looking very different to me, right? In case of sensory deception, the person has a new perception which is not there. Either the stimulus is present, but stimulus can be absent as well. Agar stimulus present hai and the person is misinterpreting it, then that is called as illusion. Agar stimulus absent hai there is nothing around, and still the person is perceiving something, then that is called as hallucination. Important to understand the difference between illusion and hallucination. Illusion is misinterpretation of a stimuli arising from an external object. So I'll give you a few basic examples of illusion. So there is one illusion called as completion illusion. ये आपने routine life में खुद भी observe किया होगा. So for example, if you are reading a book, a paragraph continuously, or you are reading a newspaper. So कई बार newspapers में कुछ words होते हैं, they are wrongly worded, wrong spellings हो सकते हैं, या फिर एक spelling या एक word miss भी हो सकता है. Still, because you are in that flow, you are not paying proper attention to it. You are just reading it very fast. You are able to complete that. For example, hey, give me that book I want to read. Here, the word be was absent. But if you are continuously, constantly reading, then you might be able to understand that it is book. You will be able to complete the missing information. So this is called as completion illusion. अब illusion क्यों बताएंगे? Because actually वहां पे there was a blank space, but you could find that it was book written there, right? So this is a misinterpretation of a stimulus arising from an external object. There could be something called as affect illusion. Affect माने कि हमारा जैसा mood state exist करता है, उसके basis पे से we might misinterpret certain things. For example, if you are very much fearful, अगर आप रात को अकेले हो और आपको कोई एक बेड पे पड़ी हुई रस्सी दिख गई, you misinterpret that it was a snake instead of a rope. So this is called as affect illusion, right? You are misinterpreting a rope as a snake, right? Rope is present, external object is present, but you are misinterpreting it. So this is illusion. Another very special type of illusion is pareidolia. अब pareidolia में क्या होता है कि here there are vivid illusions that occur without patient making any conscious efforts. So it is a tendency to perceive a specific, often meaningful image in a random or ambiguous visual pattern. So for example, this is the cross section of a cut tree, and without even making effort, many people will realize or recognize that कोई एक face है, human face की तरह है, right? So this is what a new perception that we are getting from an external object. So this is called an illusion. And which kind of illusion? This is pareidolia. Another example could be आपको बादलों में अलग अलग चीजें दिखती है, बादलों में आपको फेस दिख गया किसी का, बादलों में कोई एनिमल्स दिख गया in the clouds. So this is an example of pareidolia, right? This is occurring without even making conscious efforts. You are able to realize, you are able to see it. So this is an illusion. This is pareidolia. Now, what is hallucination? Hallucination is a sensory perception, such as visual image or a sound, that occurs in the absence of an actual external stimulus. यानी कि कोई external stimulus present नहीं है. Even despite that, the person is able to see something, is able to hear something. Specific अगर example देने जाए, तो अगर आपने लगे रहो मुन्ना भाई अगर देखी होगी, so in that मुन्ना भाई was able to see गांधी जी. He could see him as real as any other person, but surrounding में दूसरे जो people थे, they were not able to see it. So it was happening in his own mind. It was happening in his own inner space, right? So this is called as hallucination. Actually में कोई stimulus नहीं है, still you are able to perceive it. In this, for example, a patient of schizophrenia is generally, they have most of the common type of hallucination that can be seen is auditory hallucination. यानी कि कोई ऐसी आवाजें सुनाई देना जो actually exist नहीं करती. अगर person अकेला बैठा है एक रूम में जहां कोई आजू बाजू नहीं है, फिर भी उसे सुनाई दे रहा है कि कोई उसके साथ बातें कर. It's called as auditory hallucination. It could also be visual hallucinations. There could be olfactory, यानी कि smell ऐसी perceive हो रही है. It could be gustatory, taste से related, or it could be tactile hallucination. Now, tactile hallucinations could coincide with delusion of parasitosis, wherein the person feels that there are insects walking on his skin, right? So that is example of hallucination. So most common hallucination in schizophrenia is auditory. If they ask you कि organic brain disorders, यानी कि brain parenchyma के जो disorders होते हैं, उनमें कौन सा most common है? So that is visual hallucination. If they ask you कि temporal lobe epilepsy या temporal lobe damage होने से कौन सा hallucination most commonly हो सकते हैं, then it is olfactory and gustatory, right? Remember these MCQs could be important. Now, what is true hallucination and what is pseudo hallucination? That is again something that we need to understand. अब true hallucination की quality जो होगी, it will be as real as a real perception. यानी कि जिस तरह से मैं आपसे बात कर रहा हूं, उसी तरह से एक को किसी की आवाजें सुनाई देती है, अड़ोस पड़ोस में कोई भी नहीं है, फिर भी उसे उसी तरह से उसी क्वालिटी से परसीव होती है, which is auditory hallucination. So this quality is as real perception. It is beyond the control. Person cannot control. वो voice वो बंद करना चाहे तो भी control नहीं कर पाएगा. So this is not in control with the person. It is perceived as outside subjective space. यानी कि बाहर से कहीं से आ रही है. It is coming from outside, right? Generally, it is coming from an objective outer space. वो person ऐसा बता पाएगा कि हाँ वो देखो खिड़की के बाहर से लोग मुझे बातें कर रहे हैं, but actually में वहां पे कोई नहीं होगा. It is perceived in sensory organs. He feels it, experiences it. जो भी modality में होगा, auditory होगा तो ears में होगा. If it's visual, it's eyes. So we can perceive it in a sensory organ. And the person does not have an insight. यानी कि person को खुद नहीं पता कि this is unreal. Same as in case of Lagero Munna Bhai, if I have to give an example. So the character played by Munna Bhai, for him, Gandhi ji was interesting. और उसको अगर तुम बताओ कि नहीं वहां पे कोई नहीं है, then also he was not convinced, right? For him, he did not have an insight that it was an hallucination. For him, it was as real as a normal perception. But pseudo hallucination में क्या होगा? The perception the person is getting, it may not be as clear. It may slightly be in the control of the person. It could be arising from subjective space, inner subjective space. यानी person बोल रहा होगा कि शायद मेरे अंदर से ही मुझे ये आवाजें सुनाई दे रही है, या तो मेरे अंदर ही ये ऐसी इमेज बन रही है. And the insight might be intact as well. So generally एक बार अगर स्किज़ोफ्रेनिया की ट्रीटमेंट स्टार्ट होती है तो ये hallucinations जो है वो धीरे धीरे pseudo hallucinations की तरफ कन्वर्ट होना शुरू हो जाते हैं. So they are not as fixed and firm, they are not as real as a normal perception, but still the person might sometimes perceive the voices, hear the voices, but they might slightly become in control of the person, or the person starts to develop an insight कि शायद ये voices है वो किसी की और की नहीं है, मेरे ही मन के अंदर से मुझे ये आवाजें आ रही है. So that is an example. Then there are certain special hallucinations that we need to understand. So that is, one is extra-campine hallucination. So in extra-campine, the hallucination is occurring beyond the boundaries of sensory field. यानी कि एक बंदा आज दिल्ली में बैठा है and he says that मुझे मेरे उत्तर प्रदेश के कोई गांव है वहां में लोग मेरे बारे में बातें कर रहे हैं वो सुनाई दे रहा है. So that is something that is not possible. That is beyond the sensory fields. So this is called as extra-campine hallucination. Then there is something called as reflex hallucination and functional hallucination. So what is reflex hallucination? It is also known as synesthesia. Here, these are actually misnomers because hallucination के लिए जैसे हमने बताया कि कोई stimulus actually में नहीं होना चाहिए, फिर भी वो perceive हो रहा है, that is hallucination. But these are misnomers because in reflex hallucination and functional hallucination, there are actually some stimuli which are present, but उस stimuli की वजह से एक नया perception generate हो रहा है. What is a is here the stimulus is in one sensory modality and the perception of it leading to hallucination is in another modality. For example, a person after consuming a substance called as LSD, which is also called as lysergic acid, which is the substance of abuse. So अगर LSD किसी person ने consume किया है, then the person might report that I am able to hear the colors. Actually colors जो है वो visual modality में हमें perceive होते हैं. But a person says that I am able to hear the colors. So this is something called as reflex hallucination, also called as synesthesia, seen in patients who consume LSD. Then there is something called as functional hallucination. Here the stimuli leads to more than one perception and both are in the same modality and happen simultaneously. I'll give you a basic example. एक person है जिसने अपने रूम का फैन स्विच ऑन किया, फैन की आवाज उसे सुनाई दे रही है, साथ साथ में उसे कोई लोग उसे गाली दे रहे हैं वो भी आवाज सुनाई दे रही. जैसे फैन ऑफ की, फैन की आवाज भी बंद हो गई, लोगों ने गाली देने की आवाज भी बंद हो गई. So two different voices were heard. Both are voices, so both are in the same modality. Both are being heard simultaneously. जैसे ही फैन के स्विच ऑन की, फैन का आवाज भी आ रहा है, साथ साथ उसे कोई लोग आवाज भी गाली भी दे रहे हैं, उसका भी आवाज उसे सुनाई दे रहा है. So these both things are happening simultaneously in the same modality. This is called as functional hallucination. Do not mistake between reflex and functional hallucination. Very commonly can be asked in the MCQs, right? So another special hallucination is autoscopic hallucination. In autoscopy, यानी कि examination, autoscopy यानी कि autos यानी कि self and examination of the self. So the person can see an imaginary self from outside as a visual hallucination without looking in the mirror. So when I look at myself in the mirror, I see my image. But even if I'm not looking at the mirror and I'm able to see a person who is exactly looking like me, who is in fact me as a different person, as some outside, then that is called as autoscopic hallucination. खुद ही की परछाई दिखाई देना. It's not actually a परछाई because for the person it is as real as a real perception. So this is autoscopic hallucination. Then there are something called as hypnagogic and hypnopompic hallucination. So hypnagogic hallucination are the hallucinations which the person gets when the person is going to sleep. यानी कि सोने से जस्ट पहले उसे ऐसे आवाजें सुनाई देना, ऐसे कोई चित्र दिखाई देना जो एक्चुअली में एग्जिस्ट नहीं करते, which are hallucination. So this is hypnagogic. And the person might feel it when he is waking up from the sleep as well. So that is called as hypnopompic hallucination. Generally, these can be seen in various types of sleep disorders, like narcolepsy में ये commonly present हो सकता है, hypnagogic and hypnopompic hallucinations. So this completes our discussion on mental status examination. Now we'll move ahead with the MCQs. So let's see if you can answer these MCQs. MCQs, I'll give you 10 seconds to answer these questions. So here's the first question. A perception that occurs when a sensory stimulus is present but is incorrectly perceived and misinterpreted is known as. So what could be the answer? What could be this kind of a perception? A perception that occurs when a sensory stimulus is present but is incorrectly perceived and is misinterpreted is known as, what is it? Is it a hallucination? Is it an illusion? Is it a delusion? Or is it a pseudo hallucination? So try to answer this. I'll give you 10 seconds. I'll count till 10 and then we'll move forward. So what could this be? I look forward to your answers. If you are watching this as a recorded session later on, you might just write it down in your notepad and see if your answer is correct, right? So let's see what the correct answer is. So the correct answer is illusion. Why? Because here the perception is occurring and the sensory stimulus is also present, right? Remember, sensory stimulus should not have been present. So hallucination is ruled out. Delusion क्या है? Delusion is a content of thought disorder. यानी कि person क्या सोच रहा है? It's not a problem of perception. So delusion is ruled out. Pseudo hallucination is also ruled out because कोई sensory stimulus है यहाँ पे present जिसे हम misinterpret कर रहे हैं. So this is illusion, right? For example, I had given you that object which was misinterpreted. For example, a person misinterpreted rope as a snake. So that is an illusion, right? Moving on to the second MCQ. So a patient complains of tingling sensation when flashed with lights. What is this phenomena known as? एक patient को lights के साथ flash किया गया and the person reported that he gets a tingling sensation. So what could this phenomena? Is it a pseudo hallucination? Is it a functional hallucination? Is it a reflex hallucination? Or is it a panoramic hallucination? So what could this be? Let's try to understand. Based on what we have discussed very recently, try to answer this question. Very easy to understand. Light को हमने flash किया है, the person gets a tingling sensation. So what could this be? Try to answer. So the answer is reflex hallucination. Why reflex hallucination? Because both the things are occurring in different modality, right? Light ka flash hona is actually a visual stimulus that we are giving, but the person experiences a tingling sensation on his skin. So these are totally two different areas where he is perceiving. So जो perceive हो रहा है hallucination जैसा experience, that is at the level of tingling, and the stimulus is at a visual level. So both are in different modality. So that is why it is a reflex hallucination. It is not a functional hallucination. Functional hallucination तब होता जब both the stimulus and the perception that is occurring are in the same modality. The example I gave you of a fan. Fan on की आवाज आ रही है, साथ साथ उसको आवाज आ रही है किसी और इंसान की गाली देने की. So these are occurring at the same modality. You are hearing both the voices, right? So that would have been a functional hallucination, right? Moving on to the third one, a bit tricky. So let us see if you can identify this. A patient is put in this position by the examiner and he maintains this posture. So this could be an example of, is it rigidity? Is it cataplexy? Is it catalepsy? Is it posturing? So what could this be? A patient is put in this position by the examiner and maintains this posture. अब क्या हो सकता है? Very easy to understand. Just read it carefully. So the correct answer for the third question is catalepsy. Why it is not posturing? Only two confusing things are there, catalepsy or posturing. अब पोस्चरिंग में क्या होता है, इट इज पैसिव, द पर्सन हैज मेंटेन्ड इट, यानी कि एक ओपीडी में पेशेंट मेरे पास आता है, खुद ही अपना हाथ ऐसे रखे हुए आया है, so that would have been posturing. But here it is said that a patient is put in this position by the examiner. Examiner ने उसे इस तरह से induce किया है and now he has maintained it. So this is catalepsy, right? Do not forget. Moving on to the fourth MCQ. A man looks at a flower and sees the face of a ghost and becomes very frightened. एक फूल की तरफ देखता है और उसे एक भूत का चेहरा नजर आता है और वो बहुत डर जाता है. Now this could be an example of what? Is it a visual hallucination? Is it a functional hallucination? Is it pareidolia? Is it delusion of persecution? Try to answer this. I'll give you 10 seconds. Think about what we have discussed so far. एक पर्सन है जिसे एक फ्लावर के बीच में एक घोस्ट का चेहरा नजर आता है, शायद आपको भी नजर आ सकता है अगर आप ध्यान देंगे तो. So what could be this an example of? क्या आपको विजुअल hallucination है, आपको फंक्शन है, क्या आपको pareidolia है, या फिर delusion of persecution है? So the correct answer in this case is that the person actually is suffering from pareidolia. Pareidolia is an illusion. Remember, हमने एक discuss की थी image, cut section of a tree wherein the person was seeing an image of a person. अब why it is an illusion? Because एक stimulus already present है. So flower is the stimulus that we have, right? And this stimulus is being misinterpreted by us. And this is happening very automatically. This is why this type of illusion is known as pareidolia, right? अगर आज आप जाके clouds की तरफ देखेंगे, clouds में आपको कोई images नजर आ रही होंगी, आपको एक face नजर आ रहा है, तो that is an example of pareidolia. This is an illusion. It is not a visual hallucination. Hallucination आप कम बोलेंगे जब actual में कोई stimulus है ही नहीं, कोई नहीं है, फिर भी हमें perceive हो रहा है, that is visual hallucination, right? So moving on to the final, Magnan syndrome is an example of what? This is slightly tricky. We have not discussed this syndrome particularly during this discussion. So what is Magnan syndrome? I'll give you 10 seconds to answer this. Is it a visual hallucination? Is it olfactory hallucination? Is it tactile hallucination? Or is it a pseudo hallucination? Try to answer this. So Magnan syndrome basically happens when a person has ingested cocaine and the person starts to feel that there are bugs which are crawling on across his skin. So this is an example of actually tactile hallucination. Okay, so Magnan syndrome, example of tactile hallucination. So here we have discussed all the important topics as regards mental status examination, and I'm sure if there are any MCQs that come on the basis of this topic, if you have understood this topic well, you will be able to score excellent marks. This is a very scoring topic. Apply some logic and understanding behind it. थोड़े words की terminology समझ लीजिए and you'll be able to solve it. You'll be able to get good marks with this, right? This is a scoring topic. You may revise this again. You may watch this as a recording again on a fast mode if you want. So thank you very much. If you still have any queries as regards psychiatry, especially Nextillo, you can definitely ask on the application as well. You can ask directly to me in person as well. I'm available on Instagram. I'm available on Twitter and Facebook as well. My Instagram handle is @PsychiDiaries. You can ask me anytime. I'll try to help you out as a faculty of Nextillo, right? So thank you very much for Nextillo for giving me this opportunity. And thank you everyone who joined in. And thank you to everyone who will watch this as a recorded session as well. I hope this was useful. I hope this was helpful to you. If there are any queries, you can write it down in the comment section. Thank you very much.